All right. Hello, everyone. This is Mrs. Ignacio, and I have some outstanding students that are up early on a Sunday that want to talk about the assessment. And we're going to start with talking about the assessment of the cardiovascular kind of patient. So whenever we think assessment, I think ADPI. Can you all tell me what ADPI means or what it stands for?
It's the nursing process: assess, diagnose, planning,
implementation, and evaluation.
Okay, yes, fantastic. Okay, so that's going to be important. You always need to use this process in everything that you do as a nurse, not only when you're caring for your patient, but as you are actually answering these questions, because that's how the NCLEX is going to test you. It's making sure that you're using this process. You may notice that your textbooks are set up in that way. So, and if you haven't noticed already, that's okay. Take a look at your textbooks and you're going to see towards the end of the chapters, it's going to say nursing assessment. So if we're looking at the cardiovascular system, how do we assess that cardiovascular system? Well, let's look at this pictorial. If you're a visual learner, this is going to be great because it's going to tell you the things that you need to look out for. So let's start from top to bottom. So the hair of my cardiovascular patient may be brittle and dry. They may have poor nutrition. We know they're probably having some vitamin mineral deficiencies. That's why the hair is dry and brittle. It could also be due to cardiac or vascular insufficiency. And when we say cardiac, I want you to think of the heart, and we're going to actually talk about the heart in a little bit. And when we think about vascular, I want you to think about blood vessels. The blood vessels being the arteries and the veins. The arteries break into smaller little or branch off into smaller arteries called arterioles. And then the veins branch into smaller veins called venules. Those arterioles and venules branch into smaller ones, smaller blood vessels, and those are the capillaries. And the capillaries, if you remember from A&P, that's where all the action happens, okay? As far as nutrient exchange, oxygen and carbon dioxide exchange, that happens at the level of the capillaries. But if my patient has a cardiovascular issue, when we think about their circulation and all of their cells and tissues getting really good, rich, oxygen-rich blood, it's not going to happen. And so that's why their hair may be affected. And we'll also look at their lower extremities, and I'll talk about that when I get to it. Okay, so that's their hair. Their eyes may be changing because of an increase in blood pressure. Okay, so raised yellow-orange plaque under their eyelids, that's something that you definitely have to know. Gosh, the name of that condition is fatty deposits under the eyes, and we just had this in my med-surg class. I can't remember the name of it, but that's going to be under your geriatric considerations, and I'm going to have to look it up because I can't think of it right now, but I've seen that a lot, especially for med-surg and for questions that you could see in the future. So if your patient has these fatty deposits on their eyelids, that may tell us that they have elevated cholesterol levels. Okay. Also, if they have a ring around their eye, that could be an indicator of excessive cholesterol. Okay. Any questions so far?
No.
Okay. Okay. I just want to make sure that I bring this up because it's going to bother me that, okay, so bring this forward. So the cholesterol rings around the eye is the arcus senilis, and it's just, it's outside the edge of the iris. It's outside the edge of the iris. So when you are looking and shining the light in your patient's eyes, right, you're not only just looking for perla, but you're looking for this arcus senilis. Okay, let's see. The fatty deposits on the eyes, I don't remember the name. Okay, but
It starts with an X, but I don't know how to pronounce it.
Okay, well, put it into the chat, please, because
Okay.
that's something that you need to know. I have seen that on NCLEX questions. And so these are the cholesterol deposits that I'm talking about. These cholesterol deposits. Okay. Great, great, great. Let's see. Okay, let's continue. So the lips and the tongue, are they blue tinged? If the patient has blue tinged lips and tongue, what does that mean?
No oxygen.
Very good, Deborah. I think that was Deborah. Okay.
Yes.
Yes. So we're thinking no oxygen. That is concerning. Okay, xanthalasma. Okay, yes, that is correct. Thank you, Rachel. All right, thank you for helping me because that was going to bother me today. Okay, so you definitely need to know that about those cholesterol deposits on the eyes and the arcus senilis. Okay, so if your patient has blue tinge around the mouth, that is circumoral cyanosis, and they can have blue tinged fingertips and toes. You're going to see that a lot with left-sided heart failure patients. And when we look at the mouth, that's going to be the number one way that we can tell, especially for our geriatric patients, if they are dehydrated or not. Skin turgor is not necessarily the best indicator in your geriatric patient, but the oral mucosa is. Jugular venous distension, what do you all know about that? And it's okay if you don't know, just say, I don't know.
I don't know.
Okay, that's okay. So I put it into the
A lot of,
chat. Say that again.
oh yeah, it's a bulging in like the throat area, like a bulging in the neck area. I think it's like a bulging vein.
It is a bulging vein, okay? And I'm going to tell you, if you're a visual learner, if you get something in class and you're like, I don't really get it, just Google it and get the image. And because once you see the image, you're going to remember it. And that's a great way to study. So here's JVD right here. This bulging vein that you said, that's exactly what we're talking about. What you need to know is when I'm assessing this patient, they need to be up at a 45-degree angle. You can shine your pen light on this area to see the bulging vein. And once you see it on a patient, you're going to be like, whoa, okay, even this picture will make you think, wow, okay, I get it now. Okay, so that's what we're talking about for JVD. This is a goiter, that's something else. Okay, so let's go back to this so I can kind of stay focused. So with that jugular vein, that jugular venous distension is JVD. And everything that we're putting into the chat, if you're not familiar, because I know we have a short amount of time, but look it up and Google it. Look for pictures. And I'm going to share with you some links of some credible NCLEX kind of resources that you can go and they will explain things to you in detail. Okay. So, and also the other thing that you could do is when you go to class, say, you know what, instructor, I did my pre-reading before class and I am prepared for this discussion tonight. When I read, I was, I found something like JVD and I didn't quite understand it. Could you explain it to me? I will tell you that your instructors will be so excited that you prepared beforehand and they'll be happy to answer any question you have about the particular topic. Okay. All right, so jugular venous distension, we're looking at that. And whenever you have a patient with bulging veins on their necks, I'm thinking fluid volume overload. That's going to be really important for you to understand. And so fluid volume overload. Now, when we look at the chest, we're going to auscultate, and I'm going to show you a link of, okay, how do I listen to my patient's heart sounds? What do they listen? What do they sound like? What's normal versus what's abnormal? Because you can have hotspot questions on NCLEX that you will have to listen to a heart sound and you'll have to understand, okay, well, what's going on with this patient? Okay. So when we look at the chest, we're going to auscultate and let me show you this. Okay. There is the cardiac landmarks, and it's sometimes called ape to man. And sometimes it's called ape to man or all people read Time magazine. Okay. So why is this important for a cardiovascular assessment? Well, when we listen to the heart, we're actually listening to the four main valves of the heart, okay? So we're listening to the aortic valve, the pulmonic valve, the tricuspid valve, and the mitral valve. And I'm sharing my screen, and you should see a person there reading a magazine, and it says 5 areas for listening to the heart. And so with this, you have to place your stethoscope in those particular spots. You need to know what those landmarks are. So if you're a visual person, this will help you. You can take a screenshot of this if you like, but you need to know those cardiac landmarks, okay? So when we think about this, what am I meaning landmarks? I need to know that, okay, I'm putting my finger on the clavicle on the right side, and then I go below that, there's going to be a space. That's going to be my first intercostal space. Then I keep going downwards right towards my toes, and then there's going to be another rib, then there's going to be a space. That's the second intercostal space. That's where you actually have to put your stethoscope when you're listening for these sounds, when you're auscultating. Any questions about these landmarks?
No.
No? Okay.
No, ma'am, thank you.
You're welcome. Okay, so you definitely have to know that is all people read Time magazine, or ape to man is the mnemonic. Okay, so what else? Blood pressure. So you've got to know the normal range, and 140 over 90 will definitely tell you that the patient has hypertension. You have to know the normal heart rate for an adult, 60 to 100 beats per minute. Okay, for your abdomen, you're going to be looking for things like ascites. Anybody know what ascites is?
Or so like fluid buildup.
Yes, excellent. Okay, so fluid buildup. If you ever seen someone, I think that might be have a typo, and I put it into the chat. So if you've ever seen someone, they have this round protuberant abdomen, they're like, oh, this is just my beer belly. No, sir, no, ma'am, this is ascites. This is a fluid buildup, just like Deborah said. We also have to look to see if there's any varicosities, any pulsating masses. Because if they have a pulsating mass, they may have what's called an aortic aneurysm. Okay, anybody know about aortic aneurysm? Okay, definitely write that down to look it up, but I'm going to tell you an aneurysm is a ballooning of the artery. So a ballooning of the artery. So what does that mean? That means that that artery is kind of stretched out. Okay, let me just bring a quick picture here so you can see what we're talking about. What am I concerned about if my artery is ballooning?
Rupture.
That's right. Excellent thinking. Okay, fantastic. So what if my aorta, God forbid, what if the aorta in your patient ruptures? What do you think is going to happen?
You have an aneurysm.
So they have an aneurysm, but it pops, it ruptures, it
Okay.
bursts. So what's going to happen to that patient?
Bleed out.
Yes, they will hemorrhage. Yes, and so they will hemorrhage, and it's going to happen really fast because your aorta is your largest artery in the body, right? So, and it's going to happen really, really fast. So how do we assess for that? Well, we use our stethoscope and we go all the way down the abdomen, and we're going to use the diaphragm of the stethoscope, do you think, or the bell of the stethoscope?
A bell.
Yes, the bell. Very good. So we're going to be using the bell of the stethoscope. Okay, so make sure that you look up aortic aneurysm. So, because that's really a serious kind of condition, the patient the survival rate is not that good. All right, so continuing down, we're looking at the skin. Is it dry and cool? Because that may be due to the poor circulation. Well, that makes sense because we already said that the cardiovascular system is providing rich oxygenated blood to all of the tissues and cells of the body. Okay, again, we already talked about the cyanosis. Pallor. What's pallor? Okay.
Like,
It's the pupil, oh, sorry, Paulo.
Yes, pallor. And it's okay if you don't know these terms. Maybe you didn't get to it yet, but these are terms that you should definitely know. Okay, so pallor, the patient's going to have a pale skin that is not appropriate for their ethnicity. So if the patient has pallor, that may tell me that maybe they have anemia, they have decreased circulation. You could see pallor in a patient if they're getting ready to have an MI, myocardial infarction. So pallor is not a normal finding in your patient, right? And when you're looking at health assessment, you should be looking at, okay, what's normal? What do I expect to see? And then when something deviates from what's normal, you can then say, okay, why is this happening in my patient? Why do they have pallor? Is it because of cardiovascular issues? Is it because of anemia, right? So that's how you should be thinking. Now, when we look at the sacrum, we're going to check for edema and we're going to check for pressure areas in our immobilized patients. That's really important. The nails, do you all know what clubbed fingers look like?
yes, they're kind of like, I want to say like
Brittle.
almost like knots, or very thick in certain areas of the club finger.
Yes. Okay, excellent. And so I think of my favorite frog when I see this. I think of the red-eyed tree frog because that's kind of how their fingers look. And they can actually have their toes as this look like this as well. This is because of chronic hypoxia. And so again, this is just like one of the things you're like, if I didn't know what club fingers was, I would look it up, Google it, and you will always remember this when you see this picture in your mind. Okay. So what kind of patients can have club fingers? Well, my COPD patients, my heart failure patients, okay, because of this chronic hypoxia. All right, lower extremities may have absence of hair and thick skin. Okay, so when you are assessing the skin, especially of the lower extremities, you're looking for shiny, hairless patches. That tells you that the patient probably has arterial insufficiency. That means the oxygenated blood is not going to all the parts of that lower extremity. If they have thick skin, that's also another indicator that they have poor circulation. Okay. And so we also want to check for edema, that is swelling. We want to check the pulses, and we always assess the pulses bilaterally. And we also check for a decrease in sensation. Okay, sometimes our patients may not have feelings in their toes or fingertips due to nerve damage, which is called neuropathy. Okay, so this was a quick snapshot of what we're looking for in the cardiac patient. Any questions?
Oh, ma'am.
Okay, awesome. I'm going to go to my next picture that I have set up for you all. This is a circulation of blood flow through the heart. Can you all see that picture?
Yes, ma'am.
Okay, fantastic. So I like this picture because it kind of walks you through. So you all are taking anatomy and physiology right now?
No,
Yeah.
ma'am. We took it already.
You took it. Okay, so this should be a refresher, I hope. Um, and so it's really important for you to understand if I was a drop of blood or if I was a red blood cell, where would my course take me throughout the day? Where do my travels take me? So you have to understand that deoxygenated blood is entering the heart via the vena cava superior, that's above the heart, inferior below the heart, and is going to go right into the right atrium. And remember, the heart being a four-chambered pump, right? Hopefully this is familiar. A four-chambered pump, two atria, two ventricles, the atria on the top, the ventricles on the bottom. Both atria beat at the same time, and then the ventricles beat at or pump at the same time. So the right atria, that's where that blood will go through. Then it's going to pass through that tricuspid valve. Okay, so it's going to pass through the tricuspid valve. Then it's going to go to the right ventricle. The right ventricle will forcefully push the blood through that pulmonic valve to the pulmonic artery, and then that blood's going to go to the lungs. What happens when that blood is in the lungs? Well, it's going to drop off carbon dioxide, pick up oxygen. That oxygen-rich blood is now going to enter the heart again through the left atrium. So it's going to then pass through the mitral valve, and then it's going to go into the left ventricle. The left ventricle is the largest, most muscular chamber of the four-chambered heart. It's going to forcefully push blood through the aortic valve to the aorta, and then it's going to take the blood to the rest of the body. So do you see why an aortic aneurysm can be so deadly if it ruptures?
Yes.
Okay, awesome. Do you all know Dr. Dre?
Yes.
Okay, because he had an aneurysm. This was 2 years ago. He had an aneurysm in his brain and he was hospitalized. And of course, they were able to save him because afterwards he recovered and he was playing the piano at the Super Bowl. I was like, wow, his cognitive skills are still intact. When I saw that, I was like, yes, he had a full recovery. He didn't have any deficits because of that aneurysm. Okay, so he had a ballooning of the artery in his brain. Okay. And I know we're not doing neurovascular, but I just want to relate it to you because you may remember, you may be familiar with his case, or you might look it up after this session. But anyway, that is the flow of blood through the heart. What you really need to understand is the cardiac landmarks. You need to know those four valves because when we auscultate, when we listen to the heart, that's what we're actually listening to, that lub dub, the S1, S2 sound. If your patient's heart's valves are not healthy, not intact, if they become hardened, if they become stenotic, if they start to leak, that means that there is a backflow of blood because remember, the valves make sure that the blood goes in one direction. It's like a one-way street. If those valves are faulty, then blood will be regurgitated back and then that patient will have a heart murmur. Okay. And what part of the stethoscope do we use to auscultate for a heart murmur? The diaphragm or the bell? It's okay, you can guess.
The bell.
It is the bell. Okay, it is the bell. Okay, and so you will always use a diaphragm to auscultate, and then you will go back again and listen with the bell. Okay, awesome. Let's take a look. Any questions about the blood flow through the heart?
No, ma'am.
Okay, fantastic. All right, let's jump into the heart's cardiac conduction system. So the heart has its own little cardiac electrical conduction system going on. That is where the EKG, the PQRST complex comes into play. So I'm sharing a picture that you should see a heart. You should see a PQRST complex. Those are those squiggly lines. Whenever we think of heart, we see them all the time, right? People have them on t-shirts. They're symbols that tell you, hey, this is an EKG or a PQRST complex. So when we talk about the electrical conduction system of the heart, I like to think of it as a train, and there's 4 stops on this train. So it's like all aboard. The first stop is going to be the SA node. Anybody knows what SA node stands for?
It's in an atrial node.
Yes, excellent. Okay, and I think that was blessing, right? Okay, so sinoatrial node, that is the pacemaker of the heart. That's something you definitely need to know now, and you're going to need to know it for Med-Surg 1, Med-Surg 2. So the SA node is the pacemaker of the heart. In adults, that gives the atrial kick so that heart rate can be between 60 to 100 beats per minute. Any less than 60, the tissues are not going to get proper perfusion. That's where we're going to be, okay, we're going to have to do CPR for the patient because they're not getting, their heart is not pumping enough. And when we say perfusion, it's going all the way to all the cells and tissues and delivering that oxygenated blood. Okay. All right. So the SA node is the first stop on this electrical conduction train. The second stop is going to be the atrioventricular node, or the AV node. Okay, the third stop is going to be your bundle of his. Okay, my daughter asked me, she said, Mom, how come it's not called a bundle of hers? And I was like, I don't know, Erica, but it's bundle of his. So if that little story will help you to remember bundle of his, then great. The next stop is going to be the right and left bundle branches. Sometimes you'll see it, and I believe in your textbook, it's also called Purkinje fibers. Okay, Purkinje fibers. So you need to know that Purkinje fibers, and I'm just putting in the chat. So you need to know those 4 stops. Why is it significant? Well, if my patient has damage to the heart muscle, or they have some issues with the heart at the level of the SA node, what's going to happen? The AV node is going to kick in. Okay, the problem is the AV node is not going to have enough of that force to, like that atrial kick that happens at the SA node. So the heart is not going to be beating enough and as effectively. So it'll keep the patient alive for a little bit, but this is a patient that's going to end up needing CPR and, medical intervention, that kind of thing. Okay, this patient may be one that will require a pacemaker. Okay, so just to give you an understanding. Okay, any questions about the electrical conduction system of the heart?
No, ma'am.
Okay.
No, ma'am.
Okay, awesome. Now let's look at the PQRST complex, because you need to know what the sections of these mean. So that P wave, the first little hump, kind of looks like a little hill. That is atrial contraction. So remember I said the atria, the left and right atria, they actually contract together, right? So that is your P wave. So if something is abnormal or funky about your P wave, that tells me that, something is going on with my atria, because that's when my atria are actually contracting. They are squeezing blood down into their respective ventricles, okay? The QRS, that wave tells me that my ventricles are contracting, they are squeezing. So that's my right ventricle pumping blood to the lungs, my left ventricle pumping blood to the aorta, to the rest of the body. The T wave is ventricular repolarization, or simply the ventricles are relaxing. Why are they relaxing? Because they're filling up with blood. Okay, so that is what's happening with the PQRST. So if you kind of understand that when you go to med-surg and you look at these different cardiac rhythms and they don't have a normal PQRST, you can tell, oh, something's going on with the atria, something's going on with the ventricles. Okay, certain medications will give you an elongated QRS complex. And so that's, you probably, if you're in pharm right now, you might be learning about that as well. So that's the significance, trying to make those connections. Any questions about that?
No, ma'am.
Okay, fantastic. All right, so those are the things I definitely wanted to go over with you. I'm going to shift gears for a second, because when we think about cardiovascular, and I'm going to share this link with you in the chat just in case. And definitely, if these values are different, I want to make sure that you go with your textbook values. But I'm sharing this with you because when we think cardiovascular assessment, not only do we have to do our head to toe assessment, but we also need to look at our lab values. So I have this pulled up: cardiac markers and serum enzymes. So definitely, if there's a section in your textbook, and I'm pretty sure there is, that talks about cardiac lab values, you need to know what they are. All right. Creatine kinase is good, but myoglobin is good, but I want to put my time to talk about troponin. Okay, so troponin is a protein that is found, okay, in your muscles. And so increased amounts of troponin are going to be released into the bloodstream, okay, if there is damage to the myocardium. So remember from A&P, the myocardium is that thick muscular layer of the heart. Well, that makes sense. If there is damage to those muscles, then there's going to be an increase in troponin. Okay, so that tells me that the heart muscle is damaged. Okay, and so that's really important for you to understand. So when we think about these cardiac enzymes, specific enzymes will tell you different things about the heart functioning. And the troponin level is really a gold standard, is really what we look for. Now, all the other cardiac markers are important, but the troponin, I believe, is going to be the most important one. So if you had to choose and you could only know one lab value for your patient, I would want to know the troponin levels. You may have heard the word gold standard. Does anybody know what gold standard means? Okay, that's okay. So gold standard means this is the best. Okay, that means this is what we use as a definitive kind of value to diagnose the patient. Okay. All right. The next thing I want to share with you is this YouTube channel on heart sounds. So give you an idea. What does a normal heart sound like? And there may be a commercial, sorry.
Switch from
it's
TurboTax
YouTube.
to H&R Block Online, and tax season will feel just as good as all those other seasons.
Okay. Okay. So I am sharing this video. Let me know if you could see it and hear it.
I can see it.
I can hear it.
Okay, awesome. So this is, I know that y'all are not, in medical school, understood, but this series of videos are fantastic. So they also have lung sounds as well. So again, you saw those cardiac landmarks, and this video is telling you that, okay, the opening and closing of the valves, that gives you the lubbed up, lubbed up, lubbed up, the S1, the S2 sound. That's what it sounds like. And of course, we're thinking S1, your systole, S2, your diastole, right? And so this is the normal sound, okay? So the opening and the closing of those valves. So what is going to be significant, and you're going to be getting into this probably for class, is, okay, what's the abnormal? Because I know, Mrs. Ignacio, you told me understand the normal, then look at the abnormal. So S1, S2. So I know that you all are curious. Take some time to listen to the S3 sound, the S4 sound, and what does that mean in a clinical setting, for my patient. And I'll just give you a hint. S3 is not always pathological. It doesn't always mean that the patient has an issue. It could be seen in athletes or pregnant patients, but an S4 sound is an extra sound that is pathological, meaning that something's wrong with the patient's heart. Okay, so you don't have to know all of these heart sounds, but I would definitely listen to the normal, the S3, and the S4. Okay, for right now, for where you are in the program. Any questions about that?
No, ma'am.
Okay, fantastic. I'm going to just give you a little bit on study hints. Because there's a lot of information, I have students saying, oh, I don't want to read the whole chapter. Every instructor will tell you, always read the entire chapter. But how could you use your time more wisely? Well, if you know that your instructor is going to cover, say, cardiovascular system in class, if you don't have time before class, if say your class is tomorrow, go to the end of the chapter, look at the key points, read, understand, highlight, make notes about those key points. If something is a little fuzzy, write it down, because in the beginning of the class, before the instructor starts lecturing, say, you know what, Mrs. Instructor or Mr. Instructor, I did some preparation before class, and in my reading, I didn't understand this. Could you explain it to me? And I'm going to tell you, your instructor is going to be like, wow, they prepared before class. This is awesome. I will definitely explain that to you. Okay. And when you prepare before class, that also helps you to kind of get an idea of what's going to be talked about. So you won't be just seeing this information for the first time. So another way that you can prepare is at the beginning of the chapter, it has the chapter objectives. And I know this for sure in that Red Med Surge book. It has the chapter objectives. There's usually like 8 or 9 of them. As you read the chapter, before you read the chapter, look at those objectives. Okay, objective number 1. Okay, and when you read, oh, this is the answer to objective number 1. Let me go ahead and make a note of it in my book. Or if you're a read, write kind of learner, let me write some notes and say objective number 1 is on page 520, right? So that way you can, be ready to go and have it as a reference. Okay, so those are some ways that you can, be ready and more prepared for class. So when you receive the information, it's going to sink in. You kind of break up the ground a little bit. So when the seeds are planted by your instructor, then they can take root and grow, and you'll have beautiful flowers. All right, let's talk about now the Kaplan decision tree. That's what I'm sharing right now. I love the Kaplan decision tree because it helps me think critically. So when I think about the Kaplan decision tree, the first thing I need to do is, can I identify the topic of the question? What is this question asking me? Is it a cardiovascular kind of question? Is it a respiratory kind of question? What is the question asking me? Is it a positive or negative question? Positive meaning that this is something the nurse should do, something that the patient should say to show that they understand the patient teaching. Negative meaning that, okay, they should not be saying this. The nurse should not be doing this. She needs intervention, or he needs intervention from the charge nurse because they're making a mistake. The patient's safety is in jeopardy. Okay, so identify the topic of the question and then ask yourself, are the answers assessment or implementation? So remember at the beginning of our session, I said, hey, do you know what ADPI means? That's what we're talking about. Do I need more information, assessment information, to answer this question, or do I have to do something? Here's an example. Your patient is receiving a blood transfusion. They start telling you 15 minutes into it, they have difficulty breathing, they're breaking out in hives, and they have itchiness. So what is this, an assessment or an implementation?
Assessment.
Implementation.
Assessment.
Okay, so I didn't ask the question properly, but the information that I gave you was information that is an assessment information. Now my answer choice has to be an implementation, because I know that this patient has pruritus, they have urticaria, they're having a transfusion reaction. My next step, because the question is going to say, what does the nurse know to do next? Stop the transfusion. Okay, so the answer would be implementation. So I think all of you said the right thing. I just didn't ask the question very well. Any questions about that particular example?
No, ma'am.
Okay, fantastic. So now Abraham Maslow. Maslow's hierarchy is something besides ADPI, Maslow, you've got to love it, right? These are the things that make up nursing. So we have to meet the patient's physical needs first and those lower level needs. If you're not familiar with Maslow, please look it up, and we are meeting the patient's basic needs, food, clothing, shelter, that we have to meet those basic needs first. And then we have to also look at ABCs, airway, breathing, circulation, and that's the next step in the decision tree. Are these answer choices related to ABCs, airway, breathing, circulation? If I have a patient that is depressed, I better take care of their compromised airway before I deal with their depression. Because guess what? If they don't have an airway, they're not going to be alive. Okay, so that's what that is talking about. And then when you look at your answer choices, what is the outcome? If I choose this choice, what's going to happen with the patient? So for my transfusion patient, if I choose to let the blood continue to flow, what's going to happen to the patient? If I stop the transfusion, what's going to happen to the patient? You always want to choose the one that's going to have the best outcome for your patient. What you can do is ask yourself, if it's a priority question like first, next, or immediately, or you can say to yourself, what's the killer answer? What's going to harm my patient? That's going to be the thing that I need to do something about. Or you can say, if I had to leave and I only could do one thing for my patient, what would that one thing be? Okay, so that's kind of a breakdown of the Kaplan decision tree. Any questions about that?
No, ma'am.
No. Okay. I had a couple more things that I wanted to introduce to you. We've got 2 minutes left. So this video, because I think you all are getting into maybe lungs, thorax. So I really like the nursing.com kind of assessment videos. I put it into the chat. So this, she's going to show you, she's auscultating those cardiac landmarks, that kind of thing. Okay, so this is a thorax and lungs assessment. Okay, so take a look at that. That will help you as you get ready for your discussions of the cardiovascular system. Okay, I'm going to stop sharing my screen and I want to, there's one more thing actually that I think you all need to know. Did you all do the abdomen already?
No, we haven't.
No.
Okay,
We're
so
also gonna do that this time.
okay, great. Yes, because I had this pulled up. I just wanted to make sure. If this picture, if you don't have all of these organs memorized, like if you can't tell me where the pancreas is and which quadrant, if you can't tell me where the appendix is, you've got to memorize this. You have to know this. You need to know which organ is in which quadrant. Okay, and remember, it's the patient's quadrants, not your quadrants. Okay, when we're looking at the patient, they're a mirror image. So that might be confusing sometimes. You're like, okay, is that the patient's left or the patient's right? Some of you may be saying, okay, come on, that's basic. Well, patients have gotten the wrong extremity amputated because of mistakes like this. So, we don't want to take anything for granted. So you need to understand this, this diagram and where all your organs are. And I know that there's a picture like this in your textbook. Make sure you review that when we think about it. The last thing that I'm going to leave you with when we think about the gastrointestinal system and the assessment of it, you want to know the right kinds of questions to ask your patients. And I'm gonna ask you, what would you ask your patient if you're assessing their bowel habits?
When was the last time you had a bowel movement?
Yes, very good, Rachel. Okay, when was the last time? What are your bowel movements like? Okay, something that is really cool, I want you to look up the Bristol stool chart. That is really used in GI settings, and we are aiming for number 4 on the Bristol stool chart. Okay, so those are the things that you need to do and ask your patient, what is their nutrition like? Okay, when we're talking about their bowel habits, do they have any blood in their stool? And you need to know that that's called melena. Okay, melena. Okay, I'm going to stop recording